Welcome to As the Expert. It is a wonderful opportunity to share our knowledge and provide support at my goal to individuals with intellectual disabilities and their families. And I am so excited to be here today with with my guests. So I'm going to just hit and get us started. Lali, if you can do both of us on here as a spotlight, so that it's both of us that are speaking and people can see my awesome guest that's here with me today. I am so super excited to introduce one of my favorite people. And truly, I feel like I'm blessed that God has brought people in my life that have made a change in my personal life, and then have also now decided to be a part of the assignment. This is truly an assignment that I have to really encourage, inspire, advocate for others who need the extra support. And whether it's the parent or whether it's the caregiver, whether it's the individual themselves, at my goal, we exist to support families facing autism and other intellectual disabilities throughout their lifespan. And I'm blessed to be surrounded by incredible professionals, supporters, and one of my own personal friend, I call her a friend, and also a member of our board. Dr. Rosemary Merola has been an amazing colleague and friend who traveled with me to Ghana, to Haven International. She's dearly loved by many of her patients because of her commitment and work. Prior to us just coming on live, we were just talking backstage and talking about how long she's been working. And I'm just like, wow, I'm in awe of that. But I would just introduce Dr. Merola. She's the chief of division for the developmental pediatrics, and she's board certified neurodevelopmental pediatrics. Dr. Merola completed her residency at Brookdale University in Brooklyn, New York, and she completed her fellowship in neurodevelopmental pediatrics at Children's Specialized Hospital in Mountainside, New Jersey. So many of you who know Children's Specialized, she's one of their own and trained there. She's really experienced, very passionate, has worked in many various organizations, including Hunterdon Medical Center. And over the years, I think her mainstay was really at Children's Specialized. I met her when I worked at St. Peter's University Hospital. And like I say, I've personally have seen her, my son Nicholas, with her. And so if I can say that this is one of those people you want on your side. And she's agreed to come this afternoon to share her knowledge and give us some answers to questions that parents may have. And this particular series that I'm doing is called, the New Parents Series, Going Beyond the Diagnosis. And the point here is that we need to know and have knowledge, and knowledge is power. So Dr. Merola is going to be talking to us this afternoon about autism through the lifespan. So Dr. Merola, I want to welcome you and say thank you for partnering with me and the families and the individuals, and for all the lives that you've impacted and changed. We're incredibly blessed that you can choose this afternoon to share your knowledge with us. So on this note, I welcome you, and we'll yield the floor to you to share your knowledge with us.
Okay, thank you. As Genevieve said, we're going to be talking about autism through the lifespan. I don't have anything to disclose. I don't have any connections with any organizations other than being a member of the board for my goal. The objectives today are to help you recognize the signs of autism, the early signs and signs as the child grows, to understand the core symptoms of autism, the treatment options that are out there based on each child's individual findings and presentations, and also to give you some resources, which include diagnosis and intervention services. Okay, when we look at autism, autism was first described in 1943 by Leo Kanner. He saw similarities in 11 children. He saw that they were low functioning, they had severe social isolation and withdrawal, poor communication skills, and repetitive behaviors. And all through history, those presentations become part of the core symptoms of autism and hasn't really changed since Leo Kanner initially described it, except that the group of children he studied all had low functioning abilities. Autism was in his time referred to the more severe individuals. It was thought to be very rare. At that time, the affected population was 1 in 12,000 children. Hans Asperger described a similar syndrome to autism, but with different levels of impairment. It was later termed Asperger syndrome. These children had much higher intellectual potential, but still had those core symptoms of autism: social isolation, communication deficits, restricted interests and actions. Lorna Wing, a neuropsychologist, in 1995 described the difficulties experienced by autistic patients as a triad of impairments, which then helped to explain the complexity of the behaviors that presented. Her model is recognized how behavior thinking and learning could be influenced by the differences in development of communication, social skills, with limited flexibility and imagination. This is the model that helps us understand that behavioral presentation of autism. Now, the Diagnostic and Statistical Manual was developed by the American Psychiatric Association, and it started in about 1980 with its very first publication. And its most recent publication is the Diagnostic and Statistical Manual of Psychiatry, 5th edition, which came out in 2015. It gets revised as we need to understand and as we gather more information about the disorders that are listed in there. From the DSM-4 and 4R, which was some added revisions, to the DSM-5, the diagnosis changed from pervasive developmental disorder in the 4th edition to autism spectrum disorder. And there was a reason for that. Many of the sub-classifications under pervasive developmental disorder, namely the highest functioning kids, high functioning autism, pervasive developmental disorder not otherwise specified, which were high functioning kids, some atypical presentations, and Asperger syndrome, were not recognized in the 50 states in the United States and around the country, around the world, as being part of autism spectrum. And therefore, those children and adults were not getting the services they needed. So we needed a diagnosis that covered all of the presentations of autism, from mild, moderate, severe, from high functioning to low functioning, including the atypical presentations, under one international classification of disorders, using the code F84.0 to recognize all those children and adolescents and adults with the autism diagnosis, so that they can all get the services they need, whether it's academic, behavioral, mental health, and medical. The diagnosis of autism through all of its revisions have held true to Kanner's core criteria. And those core criteria are needed to make the diagnosis of autism spectrum disorder. What are those core criteria? Severe social skills deficits, social communication limitations, and restricted interests and actions. Hasn't been changed since Kanner's description. The Triad of Impairments was added by Lorna Wing to help us understand the behavioral presentations and its wide variety in children and adolescents and adults. Autistic children are like snowflakes. They're all snowflakes, but they present differently, even within the same family, even among twins, fraternal and identical. There can be variations in presentations. As part of autism spectrum as well, we understand that there are sensory and motor deficits that may be part of the clinical presentation, and it varies from client to client. There are families that have one child of many, and that's the only one child has the autism spectrum. There are other families where more than one offspring within the family has autistic spectrum disorder, but they do present differently. So what's the Dsm-5 criteria that we use? And I do it for every child that gets diagnosed. I use the Dsm-5 criteria. There's impairment in social communication and social interaction. And under that umbrella, you need to have at least one characteristic of the three domains. One characteristic of lack of social emotional reciprocity, one of nonverbal social communication deficits, and one of lack of reciprocal relationships. You have to have 3 of 3 criteria. Some children have multiple criteria under each of these domains, and some have only one. There has to be a presence of restricted, repetitive patterns of behavior, and it requires at least 2 characteristics in the 4 domains to be affected. Repetitive speech, movement, and use of objects, adherence to routines and rituals, restricted intense interests, unusual sensory interests and reactions. A lot of the feeding issues come under those sensory interests because a lot of these kids will have sensory feeding issues related to the textures. The intense interests could be the child who knows every planet and every characteristic of planets and every name of every dinosaur that ever existed, but they can't have a conversation. Routines and rituals can be ritualistic play or this need for sameness that they have. And repetitive speech can be echolalic speech, where you say, come here, they say, come here. You say apple, they say apple. Or it could be a delayed echolalia, where they repeat the dialogue that they've heard on TV shows. And they try to use that actually sometimes in conversation. It's a scripted kind of pattern. They can have the repetitive movements, those stereotypic flapping, spinning, rocking, visually stimming on objects, or even a lateral gaze of things. And the way they use objects can be very ritualistic as well. So you need 3 of 3 domains affected for social communication, and that's the most important domain that must be present to make the diagnosis. And at least two characteristics, 2 of the 4 domains affected under restricted repetitive patterns. The symptoms have to be present in early childhood, although they may not all present until the social demands are so great they exceed the child's limited capabilities. And the symptoms together must limit and impair everyday functioning. So those are the characteristics you must meet under the DSM-5. Statistics. We said in 1943, it was one of 12,000 children who were affected by Leo Kanner's syndrome of autism. Between the 1940s and the 1970s, there was an increase. It's still considered rare, 1 to 3 per 10,000 children. Between the 1980s and 90s, the increase went to about 4 to 8 per 10,000. So there was an increase there. This was based on studies in industrialized countries using an ICD-10 diagnosis, F84, to describe it around the world. The most recent studies are industrialized countries in North America, Europe, and some areas of Asia. And the prevalence in the 21st century is 2 to 4 per 1,000. Now, the Autism and Developmental Disabilities Monitoring Network also looked at it and found the current prevalence in the United States to be in the average of 1 to 68 children. The range goes from 1 in 47, where there are clusters, to 1 in 210. The increases are felt to be the result of better information available, better records kept, more stable populations at the sites where these children are identified, and improved identification of subgroups like Hispanic children and children with cognitive impairments. The statistics in New Jersey are 1 in 41 children identified. And a lot of this came from the CDC's evaluation of health and education records. So the medical and the educational records of 8-year-old children done in 2012, came up with the 1 in 41. We're seeing that increase because we're reporting much better. Every child I identify on the autistic spectrum at the initial identification gets sent to the birth registry in New Jersey. For multiple reasons, we want to track the numbers, and we want to track those numbers to understand the functional levels of the kids coming up the pipes so we can create the programs for them. And we want to report this to the government so we can get the government money in order to support these children and develop the programs. Parents, schools, and professionals working with children who are delayed are picking up these core symptoms and making the referrals earlier to pediatricians and subspecialists. New Jersey's reviewing medical and school records and capturing more children with the diagnosis. Boys are affected more than girls, and that's developmentally in all aspects of developmental medicine. The boys are affected more than girls. Mental health issues, the girls are affected more than boys. 1 in 41 boys and 1 in 189 girls are identified with autism spectrum disorder. The age of diagnosis can be made as early as 2 years of age. Sometimes if it's more atypical, we might wait, offer services, and look again. But we try to make the diagnosis as early as possible. The diagnosis should be made for all of these children by the time they're 3 to 4 years of age. And entering preschool, we should be able to recognize those core symptoms and get them the services they need. Lower socioeconomic and minority children may be less likely to receive a professional evaluation under 3 years of age, although in New Jersey, we're doing really well with that. And a lot of these kids are picked up and sent to early intervention. And the early intervention staff are picking it up and making referrals for neurodevelopmental assessments so that they can access the services these kids need. Among children identified as autistic spectrum, 30% have intellectual disability, although there are some studies that suggest it's higher, 40 to 70. Having lower IQs, it's accepted for 30% of the cases to have lower IQs. Now, we definitely see, surveilling these kids from birth to 21, an increase in New Jersey with children with autistic spectrum. From 1 in 150 in 2002, I don't know if you could see that graph, looking at them from 2002 to 2012, there's been a dramatic increase that went from 1 in 150 to 1 in 41. And some of this could be the fact that in New Jersey, we have more services than some of the other states. So there are a lot of people moving into New Jersey in order to access the services. New York, New Jersey, some of the urban areas, you can get more services than you can in the rural areas. So the numbers are in part, I think, increasing because people are coming to those states to get the services for their children. Factors that contribute. We know it's genetic. The twin studies have shown us that identical twins, monozygotic identical twins, have a much higher prevalence rate for autism spectrum than the fraternal twins, with a 90 to 95% occurrence in identical twins and a 3 to 9% occurrence in fraternal twins. That 3 to 9% occurs also when one child, one sibling in the family has autism. There's a 3 to 9% occurrence rate in other siblings. So it does increase above the general population, but it's highest in identical twins. So we know there's genetic component. We can identify genetic mutations in about 10 or 15% of people with autism spectrum and expect more will be identified as our technology improves. There are at least 7 to 20 genes that are involved in the symptom presentation of autism. That helps us identify populations of kids, recognize what families may have a higher potential to have more children on the spectrum, but it also confuses the diagnosis as well because there are 7 to 20 genes that give us this variation in the presentation. As I said, there's 3 to 9% recurrence rate in families that have one member, and that's believed that multiple genetic environmental interactions are likely. but we don't have a lot of evidence for the environmental interactions, and there's nothing we can point to. There's no absolute gene that you can say, absolutely, when that gene's affected, the kids are going to be autistic. So that makes it a little bit more confusing as well. And the environmental factors that they've studied are prenatal and perinatal events and exposures place you at higher risk. Some studies note a higher incidence in preemies, and some a higher incidence in children that are conceived via IVF. The only thing that we have found across the literature is that older parental age at conception, there's a higher risk. Now, that's not to say that young individuals can't have a child with autism, but when there's advanced parental age over 35 or 40 years of age, or even 50 years of age at conception, there's a higher risk for autism. But even that, with that, it only accounts for 0.5% of the cases. Higher socioeconomic status seems to relate to higher functioning autism and lower functioning children. We've studied the factors that could be implicated in the cause of autism, but we really haven't found any factors that could explain the overall increase. We do take careful histories. We document everything in the history so that we can look back at retrospective studies and see if we can identify populations of kids who've had similar histories to look at the factors that might be affecting it. I do genetic studies on every child diagnosed with autism, whether high or low functioning. And the tests I do are a high resolution chromosome study. I do an SNP microarray that kind of stretches the chromosomes out, looking for little micro deletions and duplications. And I do Fragile X studies on all of the children, because if you have Fragile X syndrome, there's a 40% risk of having autism. So those are the three things that I study. The tests that I refer, when I get an abnormal on those tests, I send to a genetic specialist, because then they will study that abnormality to see if that can account for the presentation that the child has. We still really don't know what predisposes children. What we do know is that vaccines have not been the causative factor in the studies that have been completed in the literature. What are the early signs? Okay. From birth to 2 years of age, lack of joint attention. And the little green spot on the brain that's on the right is the amygdala. And that's where joint attention happens. All right. We're looking birth to 2 years for lack of joint attention, that eye contact in the picture with the mommy and the child. That eye contact is there. All right. Joint attention is the sharing of things. All right. The little boy in the next picture is showing his mommy what he sees in the ocean. All right. We're looking for that lack of joint attention. We're looking for not turning to name or noise when you're supposed to do that. And that's between 9 and 12 months. Not pointing for your wants at 12 months of age, pointing and saying, Mommy, I want that. But you have to do it with eye contact. That's joint attention. Not just pointing and yelling and trying to get Mommy to figure out what it is you want. You look at the object you want, you look at Mommy, you look at the object to see if Mommy recognizes that's what you want. That's joint attention. And not pointing to show. You see the airplane. You may not be able to say airplane, but you go, ah! And Mommy, you look at Mommy and see if she's looking at what you're pointing at. The other thing we're looking at birth to 2 years is a fixation on the small parts of toys. And many of the kids will have a fixation on spinning things like the wheels of cars. So those are the earliest signs that we're looking for that tell us that this child's at risk for having autism. Joint attention is a universal sign of autism, and it's specific to autism. It's an inability to coordinate one's own attention between an object and another person. Proto-imperative pointing is the 12 months, I'm pointing to show Mommy what I want. Proto-declarative pointing happens at 14 months. I'm sharing an interest with Mommy. It's not just coming to Mommy and shoving something at her. You have to bring it to Mommy, look at what you're bringing and say, hey, Mommy, I need help with this. That's proto-declarative. Once we see joint attention is beginning in these children, within a year, functional language should start to appear. So part of the treatment is to focus on this joint attention, get the child to begin the joint attention. We know then language will follow. When does joint attention happen? Normally, at 2 months, the first thing we see is reciprocal smiling. Mommy's holding you. You're looking at mommy, mommy's looking at you, or mommy's facing you when you're sitting in your little carrier. She's looking at you, you're looking at her, she's talking to you, you're smiling at her, maybe blowing bubbles at mommy. That eye contact begins then. It's called interactive sensory integration. Mommy looks at you, you look at mommy, you made the connection. By 5 months, there's an attachment to mommy. You begin to recognize strangers. Mommy's holding you. Before 5 months, almost anybody could hold you and you're happy. Between 5 and 10 months, you begin to say, hey, wait a minute, you're not mommy. And you start to have the attachment to mommy. And you begin to be a little leery of strangers. By 8 months, mommy's carrying you into the doctor's office. You're looking around, you look at mommy, and you're looking to see if it's safe to be happy where I am now. That's gaze monitoring. We're looking for that as well. 10 months, you follow a point. Mommy says, oh, look, and puts out her hand. You look down mommy's hand to see what she's looking at. 10 months. 12 months is the proto-imperative pointing. We talked about that. 14 months, proto-declarative pointing. And also 14 months, you show the parent an object with eye gaze. So you're not just running up to mommy with a cup and shoving it at her. You're showing mommy the cup to say, hey, mommy, I'm thirsty. All right, you have to make the eye contact. And it's we're really looking for 3-point eye contact. You look at mommy, you look at the cup, you look at mommy again, because you want to know that mommy has figured out what it is you want. That's the body language you're using to communicate to mommy. You don't need words. You need the body language too. Theory of the mind occurs in the frontal cortex, all right? The frontal cortex and the amygdala, those little red spots, all right? And that's a lack of realization that others have thoughts or emotions independent from one's own. In the younger kids, it's also called mind blindness. In the younger kids, it's, I want something, all right? And mommy doesn't want to give it to me. So I'm going to scream. For hours at a time, I might scream. Or for long minutes. And mommy's trying to reason with me, but I want that thing. And all I want, I'm focused on that thing. So that's early on presentation. Later on is, you may say things very inappropriate to others and not recognize that you've hurt their feelings. So you're not in touch with those other emotions. You're not empathetic toward others. And that would be the theory of the mind that you're looking for. So the presentation in 2 to 5-year-olds. They may be not speaking at all, nonverbal. 50% of the time, the children who present to me between 2 and 4 years of age may not be verbal. All right? 20 to 30% of them may have a history of regression between 1 and 2 or 1 and 3 years of age. They were speaking, and then all of a sudden, they stopped speaking. I'll get a history. He was saying a few words. He was saying mama and dada a year, and then all of a sudden it stopped. Now, this can sometimes happen typically if the child's beginning to learn to walk. So you may have a little seesaw in that, but then the language should come through pretty quickly after they begin to walk. And if it doesn't and it regresses, we take a closer look at those children, all right? You may have non-functional language. You may be able to recite the ABCs, count to 50, know labels of many objects and animals, but you can't have a conversation and you can't express to mommy that you want juice when you want juice. There's an inconsistent use of words that can be seen sometimes, and neologisms, made-up words, or a combination of words and gibberish. There's a dissociation between the form of language and the function. The form of language, syntax and articulation may be increased, but the function of language, pragmatics and social use is decreased. Self-directed play is seen in the 2 to 5-year-old. Parallel play or solo play or very inappropriate play. They may not be interested in their peers or their environment. They may be focused on spinning objects, hard comfort items, which could be strings, sticks, toys. They have to have one in their hand no matter where they go. Joining in play only if the peers are doing what they want. Like parents will say to me, oh, but he plays with the other kids. So I'll say, well, let me look at a tape of him playing. And that's really helpful to me to see. And sometimes the child's running when they're running, but there's no real interaction. There's no eye contact. There's no, hey guys, what are we doing kind of thing. They're just following the leader. And so I'll try to explain to the parents that there's no joint attention there. They're really not engaged to the full extent in being connected. And that's what we want to focus on, to get them connected with their world so they can then progress through the stages they need for good social interaction. They may have repetitive actions. Toe walking is one of the earliest signs, or running, pacing back and forth, sometimes making noises, sometimes jumping back and forth, running in circles, spinning themselves or objects, sometimes having a string and spinning it constantly, or a toy and they turn it around to spin the wheels on it. Lunging back and forth. This is seen in a lot of the lower functioning kids, where they're not just running, but the top part of their body runs way ahead of the bottom part of their body. And they may have obsessive compulsive repetition and ritualistic play. And if you interfere with that play, they get very upset. Some of the kids will get upset and they'll just reorganize to put the things back in line. Some of them will have meltdowns when you miss a line, or when you don't sort the objects the way they want you to sort them. Restricted interests, only interested in cars, dinosaurs, Legos, letters, numbers. And repetitive speech, echolalia, immediate, they repeat exactly what you say. Or delayed, they recite the dialogues of TV. And mom will usually tell me, oh, that's from Peppa Pig, all right? Scripting, they use pat phrases and to express themselves. And they're trying, some of this they're learning in therapy with the speech person. I want juice. I want outside. I want food. So we'll teach them through scripted phrases so they can express themselves and will reduce their meltdowns. But the phrases they use are always the same phrases. In the higher functioning kids, they may be very pedantic or formal. Well, doctor, how are you today? And their speech patterns may maintain this formal pattern. In the school-age child, 6 to 12, there's inappropriate play. They invade other space. Their play is immature for age, and the interests are immature for age. They may have a strict adherence to the rules of the game, and you have to follow the game that way. You can't vary the rules. That's that need for sameness. They may be able to make small conversations or some reciprocal back and forth speech, but they cannot sustain the conversation unless it's very self-directed and fixed on their preferred topics. They cannot read the verbal cues of others. They may go up to kids and start talking about planets and not understand when these kids are not interested. They may be off topic in conversation. They can't maintain friendships, socially awkward in groups. They don't want to interact with peers, prefer adults, no interaction, or they may have no interaction with others. They may have the odd behaviors, self-stim behaviors like the spinning, flapping, pacing, jumping, lateral gaze of things. They may visually stim on a toy over and over again. They may have an odd scripted speech pattern, a monotone speech pattern that lacks prosody or the melody of speech. In the higher functioning children, they may be in regular class with or without supports, may have difficulty socially. They may be more pragmatic or literal thinkers and have trouble with the abstract reasoning, and may have the odd behaviors and rigidity. So they may have more behavior problems than the academic problems. In the first few grades, like kinder, first and second, if they're very bright and they're very savant, they already know the information, they've memorized it. Some of the kids have hyperlexia, they can read, but they don't really understand the stories, and they can't really reason things. The lower functioning kids may be nonverbal or have a higher expressive language than receptive language. They may need special education classes or other supports. They may have trouble making decisions and may have behavior problems when they don't understand what's going on. So some of the behaviors that we've seen at any age in autism can be ADHD, hyperactivity. That could just be part of autism with sensory regulatory issues and defiance when things don't go their way, or they can be ADHD comorbid, co-occurring with autism, and sometimes it's hard to tease that out. We begin with behavioral approaches to that, and when we see there's an impulse control issue, we might have to treat that. Self-injury can occur in these kids. Very commonly, it's head banging, hair pulling, biting, scratching, skin picking. There may be aggression to others, hitting, biting, kicking, throwing. Pikas, the ingestion of non-food items. Could be dirt, soil, sand, anything they pick up off the floor, paper. And they may have rigidity or obsessive compulsive behaviors that can manifest as ritualistic play in action, a need for sameness, difficulty when any routine is changed, like making transitions, especially from a preferred activity to a non-preferred activity. And the stereotypics. This lower picture of the little boy in the light bulb, he's visually stimming on that light bulb. The lining up of toys is ritualistic play. And the pacing, the running back and forth, is part of some stereotypic behaviors as well. Okay, associated findings in autism can be intellectual ability. Their IQ can be low, average, or high. 30% of kids, as we said before, have intellectual impairment and learning disabilities. Language impairment can be mild, moderate, or severe. It can give rise to behavior problems when they can't express their needs. Or it may be precocious in the higher functioning kids, that making the diagnosis more difficult, where we may see more of that ritualistic need for sameness, meltdowns, but they're able to speak. When you're talking to them, though, they may not be able to follow all the conversations. They may constantly bring you back to the topic they want to discuss. Genetic findings. Down syndrome children can have autism. Fragile X, 40% risk of autism. Rett syndrome, there's a risk of autism. It can occur with microdeletions in the 7 to 20 chromosomes. And when I do that SNP microdeletion, I'll find microgenomic studies, I will find some of those deletions and duplications and then send to the geneticist for further testing to see if this can account for the child's presentation. Medical issues can affect autism. Seizures tend to peak at 3 years of age and in adolescence. They tend to be more of a poor prognostic indicator in adolescence. 15 to 20% of children diagnosed with autistic spectrum may have seizures as they progress to adolescence. GI problem, digestion issues, feeding disorders, sensory or behavioral can occur. Allergies and immunology disorders can be associated as well. Psychiatric conditions, anxiety, depression, mood disorders, ADHD, and aggression towards self and others. When they're frustrated by an inability to communicate, aggression may show itself. When parents and clinicians try to change their preferred repetitive behaviors, you may see aggression as well. So, what is the intervention? All of these interventions can be delivered to children through their lifespan. ABA and applied behavioral analysis, which is a very strict behavioral approach to children. It's accompanied by a board-certified behavior analyst who will help take care of the negative behaviors and monitor the ABA support that's being given to promote more positive language and attention while you're reducing the negative behaviors. Speech therapy at any stage may be delivered. Early on may be to help you express yourself and your needs verbally and non-verbally. And later on, for more of the abstract reasoning, for more of that pragmatic learning that needs to go on, and for more of the gestural language you need to learn. Occupational therapy for sensory and motor issues. Physical therapy for gross motor issues and low muscle tone. Life skills training to get you to be independent so you can have independent living and a higher level of functioning. Social skills training throughout your lifespan, because as you move from a toddler to a preschooler to a school-age child to an adolescent and a pre-adolescent and to an adult, well, the social skills training that you need differs as your needs progress with your development. Vocational training may be part of it. Individualized educational planning for these kids is important so they get the services that they need. Academic, social, and behavioral, and accommodations at school, even for those children in general education classes. Even accommodations at the college level as well may be given for those who are able to attend college. Applied behavioral analysis is a specific approach to the management of autism at all ages. It's the only treatment in the literature that's considered the hallmark of care for autism. Early on, it's to develop attention, connectivity, and ability to express your needs. Later on, it's to work on the pragmatics, understanding emotions and feelings of others so you're more appropriate with your interactions. It's needed to help the child develop that joint attention, joint referencing, connectivity to their environment, language and communication skills, and later daily living skills. If behavior problems present, along with the ABA therapist, is a board-certified behavior analyst to do the ABCs of behavior management and functional behavioral analyses. You want to know what preceded the meltdown, why the child did it in order to change that behavior, and help develop a plan of action that addresses the negative behaviors and promotes the positive. Parent training is a part of ABA. They come in, they learn the child, what works, what doesn't, what the child needs, and then they parent train. So when they leave, the parent is doing what they need to do so the child's not confused, they're not getting mixed messages, everybody's working with the child in the same way to promote everything that they need. The consistency of approach prevents negative behaviors and promotes language and learning. Speech therapy. When the child has significant speech deficits, they're at risk for social skills deficits. If you can't speak, how are you going to communicate with others? Audiology exams have to be done by a pediatric audiologist to make sure that all of the speech sounds are heard. If we don't get a good study, we keep repeating it annually until we get enough information to feel satisfied. If we're not sure whether the child hears, we may do a sedated study in the younger children just to make sure that their hearing mechanism works. Speech on an individual basis is delivered to the nonverbal child and to children with significant receptive language deficits. Speech groups are used at school and privately to help develop those social communication skills, help you make and sustain conversations, have reciprocal language interactions, learn how to read and use gestural cues so you're not walking up to somebody and inappropriately speaking to them about a topic that they may not be interested in, and learning how to navigate play and deal with conflicts using words and not actions like pushing or pulling or hitting. Social skills groups usually begin 7 to 9 years when they're focused on developing social etiquette and the behaviors for social interaction. Early on, social skills groups can begin between 2 and 4 years of age under the leadership of the ABA person and a speech pathologist to develop those skills that help you communicate with children your own age and older. Occupational and physical therapy, when there are motor and sensory needs, you need OT. When there's physical therapy and gross motor skills and low muscle tone, physical therapy may be added. All autistic children have sensory integration deficits. Some have minimal, some have maximal. Some are sensory avoidant, some are sensory seeking, or a combination of both. The sensory avoidant child may be fearful of noises and cover their ears. The sensory seeking child may touch everything in their environment, lick, sniff, and mouth everything because they're orally sensory seeking. They may invade other space because they need that close touch. All right, so we feed the sensory seeking child and we desensitize the sensory avoidant child with the therapy. Many children have fine and gross motor coordination issues, so PT and OT may be added. Feeding disorders and GI disorders. The feeding disorder can be behavioral. Many times it's behavioral and sensory. Sometimes it's sensory alone. All right, and depending upon whether it's sensory alone, a speech therapist can address that. If it's behavioral and sensory, you may need more of a team approach with a psychologist to deal with the behaviors, speech and OT to deal with the sensory, and OT with some of the behaviors as well. GI disorders are treated. The most common problems are food allergies that are treated by gastroenterology and allergy immunology. Elimination disorders, sometimes due to the sensory integration, can be treated with a behavioral therapy approach, with or without medications. Psychiatric problems can be associated with autism spectrum, ADHD being one of the most common, and anxiety. These kids may have obsessive compulsive rigidity that may or may need to be treated. We always first focus on the behavioral support. Unless nothing is happening with behavioral support, we might add medication for these problems. Depression can occur in high functioning children, especially those who used to be called Asperger's, because they recognize there's a difference and they don't know how to fix that difference, and it can lead to depression. They may have success making some friends. They may be teased or bullied. I'll tell the parents, if they like sports and they're good at it, or if they like martial arts, getting them involved in that is good, because these children then carry themselves in a more self-assured way and they're less likely to be teased or bullied. Aggression to self and others can occur when they can't communicate their needs, when their preferred vocalization and actions are challenged by others. And these kids sometimes need medication as well as behavioral planning. Early identification and intervention is extremely important. The earlier we make the diagnosis and intercede with the specific therapies, the better off the children are. There's plasticity of the brain throughout life. We're seeing that in older people who have strokes. We can bring back some of their skills and recoup throughout life, but most significantly in the first 5 years of life. So we definitely want to early diagnosis and recognition. Autism spectrum presents differently through the lifespan, and kids require different interventions: medical, neurological, educational, and behavioral. The rehabilitation needs have to be addressed through a combination of medical, educational, and behavioral supports through their lifespan as well. The importance of early diagnosis allows the infant and child to begin rehabilitation and education early. The medical and behavioral supports allow the parent to become an integral part of the team. It can prevent the development of negative behaviors, anger, frustration, and aggression, which we want, because that can hold the child back from learning and make them unable to communicate their needs. Parents need to be taught the best approach, so there's consistency of care between parents, clinicians, and the children to ensure the best outcomes. All right, the rehabilitation needs. Early intervention between birth and 3. It's in the natural environment. It's in the home. And you can get all of the services, PT, OT, speech, and behavioral support in home for these kids. If you suspect that your child's on spectrum, getting a pediatric assessment, they will do a test called the MCHAT, looking at risk for autism in kids around 18 to 24 months of age. They'll do a Denver developmental to look at where the child is, and they may refer to a specialist like me or a neurologist to look at the child. You can call early intervention yourself and get an in-home intervention. The number is the 888 number. You can go on email and get it. There's a website as well. And you can refer your own child to early intervention. If they suspect that the child's on the spectrum, they'll send to the pediatrician or the subspecialist for further recognition of the issues. ABA and BCBA therapy is recommended by a pediatrician, a developmental specialist. Speech and speech feeding therapy or team therapy is usually recommended by the pediatrician or the subspecialist. OT is usually involved in the care of the young child on the spectrum. Many times in early intervention, the children come to me, they're already receiving DI, and DI, the developmental interventionist, is already doing some ABA with the child, and they're doing OT to look at the fine motor and the sensory issues, and they refer to me, and then we add the ABA and speech and other things that they might need. Physical therapy is added if there's low muscle tone and gross motor delays. The child 3 to 5, many times the parent says he's not equal to his peers in pre-K, or I notice when he's playing with the other 3 or 4-year-olds, he's not the same. They'll bring that up to the pediatrician who will do a developmental assessment and may refer to the child study team already, or to a subspecialist. You usually contact the school for an evaluation, and they, in the 3 to 5-year-old, will develop an individualized family service plan. It's based on the Individuals for Disability Education Act, which is a public law that addresses education of children 3 to 21. There's parental involvement in the development of the plan of action, and that's why it's an IFSP and not an IEP. And they begin by bringing the physician, primary care provider prescription, or developmentalist prescription in as well. Many of them, if they suspect autism in the school, will send you to a developmentalist to make the diagnosis. Child study team assessments will happen, and it's a multidisciplinary assessment using standardized tests. Some of them are similar to what early intervention has done if the child's low functioning, and many of them will include, if the child's higher functioning, a cognitive assessment as well as an academic assessment and a social assessment using the standardized tests that are acceptable for children 3 to 5. Related services can be added by doing PTOT or speech evals, and ABA will be added as well, usually through the psychologist at the school. 5 to 21, when children are delayed, either cognitively, behaviorally, or academically, they'll develop an individualized educational plan. Again, it's based on IDEA, which is the public law for disabilities with individuals with disability Education Act for children 3 to 21. A child study team will meet. It'll include a psychological with behavioral assessment, and life skills assessment, educational assessment, which is academic testing, social history, and individualized OTPT and speech as needed, and ABA may be added as well. Special education class for low functioning students will be offered with and without ABA. If you're on the spectrum, you may get ABA and BCBA services with speech and OT. Special education classes can be multiply handicapped classes, lowest functioning class with ABA, or a multi-handicap class without ABA if you don't need it. For behaviors, language learning class is a less restricted environment in the 3 to 5 age group and the 5-year-old age group. That's still special education class. It may involve ABA and may involve PTOT and speech. Inclusion classes are general education classes, but you need an IEP. Some schools, you'll need a 504 for an inclusion class, which is a mixture of typical children and atypical children with accommodations within the IEP, and PTOT and speech if needed, and behavioral support as needed. That may be ABA or may just be regular behavioral support. Social skills and counseling will be needed through elementary, middle, and high school, and those will be addressed either privately or within the school itself. High school. If the autistic child is high functioning, average to high average, with good academic skills and minimal behavior and social needs, they may be in a general ed class with the focus on academic program and college prep. Many high functioning adolescents on the spectrum who have an interest in STEM classes, science, technology, engineering, and math, may go on to college with accommodations under a 504, which is under the Rehabilitation Act of 1975. There are some colleges that accept adults with autistic spectrum disorder. You can go on www.thinkcollege.org. Caldwell College, Fairleigh Dickinson, Seton Hall, NJIT, and TCNJ all accept kids who are on the autistic spectrum. If the adolescent still has learning problems, social and/or behavioral problems, they may not be able to go to college. The problems need to be addressed through counseling, medication, private behavioral counseling, as well as counseling in school. Social problems can be addressed in the school or privately in social skills groups. If they're not academic material, they may go into vocational and life skills training program, which usually begins around 10th grade in high school. And the focus is on getting them to be independent livers, to be able to live on their own or in group home situations, and function in society when they can. The decision is made early to mid-high school to focus on either college prep, combined academics and vocational programming, or a focus on vocational and life skills, depending upon the functional level, how many behavioral problems and learning issues they have, and social issues as well. The adult with developmental disabilities after 21, you really need to be recognized through DDD. You need SSI, you may need Medicaid for any medical coverage you need, and followed through DDD. And that's based on your intellectual and occupational functional level, based on your self-help needs and life skills dependency or independence. The outcomes span the entire range. Level of functioning, academic, adaptive, and language will more accurately predict the outcome. The worst prognosis is associated with low IQ under 70, no meaningful speech at 5, seizures, especially in adolescence. If you remain as an adult very aloof, and females tend not to do as well as males of the same functional level. Better prognosis is associated with early diagnosis, appropriate treatment, positive experiences in inclusion in natural settings, lack of behavior problems and psychiatric comorbidities, and interest in and ability for sports. That's my opinion. I've seen those kids do well socially because they were accepted in the groups, especially boys that are sports oriented. 10 to 25% may outgrow the diagnosis to the point where if you saw them now, you would say, gee, you sure he has autism? But there are some oddness, there may be some oddness to their social presentation with some odd behaviors persisting. Better functional outcome of children and adolescents is strongly related to the IQ, and it has to be measured formally with adaptive tests. Children with early language and higher IQ tend to have greater academic and employment success. Children with lower IQs tend to have poorer outcomes that are less robust in response to their treatment, but they still may have qualitative and behavioral improvements. Behavior problems and the inability to care for oneself, one's personal hygiene or their life skills, ADL skills, tend to have poorer outcomes. In summary, selective or greater impairment in social interaction and social communication is the hallmark for the DSM-5 diagnosis. You really must meet something in all three of those domains of social communication to be on the spectrum. Otherwise, you're more atypical or more of not otherwise specified autistic spectrum. There are multiple etiologies with strong genetic component. The environmental influences are being looked at, but not clearly understood. It's a lifelong disorder demonstrating different appearances at different stages and progressing through social and academic dependency and through their lifetime. Importance of early diagnosis cannot be overemphasized. The need for sustained report through the lifespan is important, and supports may be medical, academic, social, and mental health. Important contacts are going to be given. My goal can print this lecture out for you and give it to any parents who want it. The early intervention numbers here. Perform care, we utilize when ABA services are not supported by your insurance enough. You may want to go through Perform Care. You sometimes have to go through DDD and Perform Care in order to get it. You'll get limited 2 to 3 months of ABA services for life. So you might not want to utilize that just yet. You can get behavioral supports as you need it with board certified behavior analysts and therapists that come into the home, monitored by BCBAs. And you can get that whenever you need it through the lifetime. You can get respite services as well. As far as the school's concerned, knowing SPAN exists, Statewide Parent Advocacy Network. If you don't understand why the school may or may not be giving you the services, you want to contact SPAN to understand the laws as they change from year to year, and so that you know what your arguments can be when you go to the school. And there's an email for SPAN there. Resources for parents. In New Jersey are these New Jersey Gov resources. My Goal is a great resource for all parents and children on the spectrum. And I've given you their email. I give that to everybody when I diagnose them, because I think My Goal does a fantastic job educating parents and supporting them and their children. Resources for the older adults are some of these. I don't know if Robert Menendez is still an advocate for autism, but it was at some point in the past. And these are some blogs you can get involved in to understand what's out there for children with autism as adults. And that's the end. And I'll entertain any questions you might have now.
Wow, what an amazing presentation. I'm so amazed. You could talk for 1 hour and do.
I know, I tend to have diarrhea of the mouth. I just go on and on forever, but yeah.
Yeah, no, it's really a blessing to have you share with us this afternoon. It's such a breadth, and I for parents who are watching, or individuals who are, you felt like it's a lot of material. The video will be on our YouTube station. It's also going to be on Facebook for you. We will put it on our website as well too, so you can go back into the material and listen. I know there are going to be some questions that people will ask, but I wanted to ask this question. Like I said, this is an amazing presentation. Can you talk a little bit about the role of like MRI, EEG, any kind of scan, ADOS, what's all that, and where is the role of that in diagnosis?
The MRI really is not done. A lot of the kids will present with a large head. You don't do it just for large head. There has to be a reason. There has to be neurologic findings that are generalized or focal to get an MRI, or regression. Regression that's atypical, usually. The EEG, I've sent kids with regression to the neurologist. If they don't find anything on the physical and they're not suspecting that the child has seizures, because these kids can have staring episodes. And I'll say to the parents, when they're staring, are you able to bring them back to point? When they're staring, are they twitching? All right, you can't always do the hyperventilation test on the kids to look for petit mal seizures. If they're staring a lot and the teacher's seeing the staring and the parents are seeing the staring and the child doesn't seem to be connected during the staring, then I'll send that child to the neurologist, and the neurologist may do an EEG. They like to do video EEGs. It's sometimes very hard to get video EEGs on the kids. They don't want to keep the probes on their head in order to do it. The video EEGs are 24 to 48 hours. They want to see the activity happening on the video and then look at what's happening on the EEG to see if it's a pattern that is recognizable as seizures. The EEGs that used to be done in all of the kids that regressed, they were looking for something like Lennox-Gastaut, which is like a very abnormal picture on the EEG for kids, but you'll see significant language regression. You may also get motor regression in those kids as well, and cognitive regression that we're not seeing in those typical kids between 1 and 3. They'll begin to learn speech. They're starting to say mama, dada, and words, and all of a sudden it stops. And then they go into early intervention and it starts progressing again. They start increasing. So it's kind of that, they're within that 20% of kids that show regression, and it's not neurologically based. If I find something focal or if I think it's atypical in its presentation, or if I feel the child may be having seizures, I'll send to the neurologist for an MRI and for an EEG assessment. Whether the neurologist does it depends on their assessment of the child as well. But it's more for those kids that have a much more atypical presentation than just the, I lost a few skills and now I'm gaining it back again. And I did have one child that I sent for a neurological, and he had lost the ability to write. He used to write words and things like that. But in the end, when they did the studies on the kids, the MRI and the EEG, what they found was that year that he was out of school for the COVID, the virtual, he regressed significantly because of that. And he was beyond 5 when I saw that regression. And mom had it on tape, what he was able to do that he couldn't do again. And I thought it was more atypical, and that's why I sent for the neurologist to do the MRI and EEG. But in the end, it was just from not being in school. These kids tend to regress even in the summer when they're out of school. They go to school through the summer, but in August, they're out of school. And unless they have a lot of activities, there'll be regression in their behavior and some regression in school. I'm seeing even in the typical kids who've been out of school a really long time because maybe the school had COVID and they kept closing and everything was virtual, that they lost a year of education. So for the autistic kids, it may affect them even more being out of school as well. But the MRI you have to have very specific reasons to do the MRI, and it has to present with something generalized or focal on the neurological, or when you're suspecting seizures, you'll do the MRI and the EEG. So that's not always needed. As far as the ADOS is concerned, for those children I'm not convinced are on the spectrum, I will send for an ADOS. However, it's very difficult to find someone to do the ADOS now because a lot of the places that were doing it are doing virtual interventions now, and you can't do the ADOS virtual. You can do the autism diagnostic interview, but you cannot do the autism diagnostic observation scale. It takes usually an hour to do the test, and then to interpret the results takes a few hours of review as well. And there are only 2 or 3 places in New Jersey doing it, and the wait list is very long. And if I am just questioning the diagnosis, I'll put the child on spectrum until I can get the diagnosis made and confirmed, because I don't want them to miss out on services. So I'll get some ABA and I'll get them some services, and I'll see them maybe if they're younger every 6 months to a year to follow their progress. But the ADOS is not done by everyone. It's not done by a lot of physicians because it's very time consuming.
Right. Thank you.
Okay, go ahead. Sorry.
Thank you for that clarification. So I often get this question from parents. When they come to see a neurodevelopmental pediatrician, what should they expect? What would that visit look like? Because people are coming in thinking that some blood work will be done or something, some kind of scan. So they're not sure what the neurodevelopmental pediatrician does. So can you explain?
That was in the other lecture that you couldn't print up. A neurodevelopmental pediatrician or a regular pediatrician is going to do a good physical. No matter what, we'll do a good physical and neurological. We're looking for those focal findings. We'll look for generalized findings. If I see a child who has low muscle tone, I will send to neurology, because low muscle tone might buy them an MRI as well, because that can be more of a generalized neurologic presentation. If it's just the low muscle tone that's seen in sensory integration, but it's not really affecting strength and movement, then that can be seen in autistic kids. But I do a physical, I do a complete neurological, I do a developmental. I want to know their functional level. And I will do a Dsm-5. I'll look at the Dsm-5. I'm looking for those symptoms. I do a childhood autism screening scale. Sometimes if the child's more atypical, I'll do a Gilliam autism rating scale. And I use that as an autism diagnostic interview, because it's what the child looked like through their lifetime, from infancy to when I'm seeing them, maybe between 3 and 5 years of age. I'll get the parent to fill that out. And I'll use that as the autism diagnostic interview and the childhood autism rating scale as the autism diagnostic observation scale for me, looking at the child's presentation to see where they fall on both of those. Sometimes there's a discrepancy. The parent's history may put the child on the autistic spectrum, but my actual observation may not. Those are the kids that I might question the need for an autism diagnostic observation scale. And then I will do, I don't do the social questionnaires unless the child is older and has more language. If I'm seeing the child later on as a second opinion and the child was already previously diagnosed, I will do a Gilliam Autism Rating Scale because I want to know where the child was. Since I may see them at 10 for the first time, I have the parents tell me what they were like before, because after partial treatment, the child may look different. And then I have to concentrate on other things when I'm looking at the child to make the diagnosis. But that's what I commonly do. I'll do behavior scales from the school in children. I do the Vanderbilt scales to look at ADHD symptoms and some anxiety. I'll do the pediatric symptom checklist completed by the parent in children under 11. And if the children are more functional, after 11, they'll do one of their own pediatric symptom checklists called for youth. If I think there's anxiety, I do the SCARED, which is the SCARED scale for parents to fill out for their children and for children over 11 to be filled out by themselves. I'll do the PHQ if I think there's depression as well. So I'm doing psychiatric scales as well to look for the comorbidities in children. But many of the kids I see for the first time are between the ages of 2 and 5. That's when I'm seeing them for the diagnosis, either being referred, some of the younger ones being referred by early intervention and later by the preschools. Or sometimes if they're in speech therapy, they may refer, the speech therapist may refer if she sees pragmatic issues and is suspecting that the child may be on the autistic spectrum as well. They'll send to a developmentalist, or the pediatricians will do that and send to me for doing a more in-depth evaluation. I do blood tests only on those children that I suspect need them. If the child is, having a feeding issue and is drinking milk and not eating anything, I might look for some iron deficiency in that child. If they have picas, I'll look for iron deficiency in those children as well and do studies there. I'll do vitamin Ds with that. I find some kids have low vitamin D. Some adults have low vitamin D. We don't go outside as much as we used to. We're covering up, so we're not getting the benefit of vitamin D. So whenever I do blood tests, I might throw vitamin D in there. The genetic testing is done on the autistic kids and the globally delayed children that I see, with or without autism, to look for a genetic cause for their disorder, which might prompt the need for other studies to be done. I don't do the MRIs and the EEGs. If I suspect the need for that, I'll refer to a neurologist because they'll do the test and they'll read the test as well. But that's, the assessment that I do. It usually takes 90 minutes to 2 hours. And follow up, if I have to retest them to look at developmental things, I'll do educational things too on some of the autistic kids. I'll do an educational screen, especially if the parents coming to me for a second opinion because they feel the school class is not appropriate. I'll do a wide range achievement test and a little cognitive screen to see if my findings match what they're getting at school, to see if they need more academic services. But those are the things that I'll do.
Oh, wow. That's a lot. And I hope for parents who have been confused now have a clarity on what should be done when they go to see a neurodevelopmental pediatrician. So I'm going to open it up. If the few people joined us in Zoom room, if there are any of the parents that are here that have questions for Dr. Merola, as you saw, there's a breadth of questions. Pat, I see that you have your hand up. Go ahead.
Good afternoon, Dr. Merola. I have a question. You just mentioned about 544 plan and IEP. My son he has IEP, now he's in 7th grade. Is that going to change when he gets to high school?
It might. Sometimes they can keep the IEP depending upon what services they need. If they need an inclusion class, or if they need some special needs classes, pull-out services, or PTOT and speech, they'll need an IEP for that. If he's in general ed and he only needs accommodations for behavior and learning, they might do that under a 504 plan.
Because it's an inclusion class, and the reason why, is there any way I can fight it? Because I don't want him to be in 504 plan, because the IEP helps him a lot. He has an aid, he has extra time when he's doing his exam or text. They put in a separate place. You know, he has so many accommodations.
Are they offering that under the 504 plan? Some of the schools they're not. Okay.
They're not. So that's why I fought for him to get IEP, because on that 504 plan, they didn't give many of those the plan support that he needed. So that's what I'm saying, that if it happens that they change it, is there any way I can fight it? Because I want him to be on that IEP until graduate that school, because the school is it started from kindergarten up to the school and on 12th grade. So I want him to make sure that he stays on that IEP until he graduate 12th grade in that school. If it happens that they take him out, is there any way I can fight it?
When did they last do an assessment on him?
We're doing one this Wednesday.
They're doing an educational assessment on him?
Yes, education and IEP plan. Well, yeah, we're doing one on this Wednesday. So I'm not gonna be there, but we're gonna do it through Zoom because of the pandemic, so we can't be in the building and everything. But
all right. So it really depends on what they find, what they're going to offer him. You know, I need to look at the IEP and the testing that was done to see if you could argue for it. The other thing is to call SPAN. And I gave you those numbers in the report. The Statewide Parent Advocacy Network, if you call my office on Monday, you have my number?
No, I don't. But,
all right, it's 732
732
339
339
7045.
7045. Where is your office located?
Oh, I haven't seen your son?
No, you have never seen my, no. I'm just
all right.
Go family, no.
All right, but if you call, I can give you the number. I don't have the number memorized.
Okay.
But I do have it in my office. You could say that you attended my lecture and I said I'd give you the number. If you wanted me to take a look at his, see, the thing is, I don't have a lot of openings for a new patient. I was
gonna say, Pat, you can send it to me and then we can connect offline with that.
Okay, then maybe we can connect offline. I could take a look at it. But if you contact SPAN and there's anything in the IEP that you could argue for, I can give you a direction to go.
Okay.
All right. But give my office a call and tell Maria, my secretary Maria, that I told you could call because you're looking for the SPAN telephone number.
Okay.
And then you call SPAN because that's your advocate. So if you see something on the IEP that you want to argue for, you want your SPAN representative to be there with you so that you know what's accepted and not accepted, what you can't argue for. Okay?
Okay.
Excellent. Michelle, you have a question or?
I do. Hi, everybody. By the way, hi, Dr. Merola. Very informative. My son, my family and I were new because my son is 2.5 now. So he was diagnosed, right when he was a little after he was 2. We did get him into early intervention early. Like I put him in as soon as his pediatrician told me to, when he wasn't hitting any of his milestones when he was 1. Still struggling a bit. My question is that he's about to be done with early intervention because he's about to be 3 in 2 months.
Okay.
He did just have his follow-up with the ICD physician at my job at Hackensack, because I work at Hackensack Hospital, with the APN. Not yesterday, I'm sorry, Friday. She says she still wants him to continue occupational therapy And
Okay.
she also wants him to start physical therapy because the toe walking is still really bad.
Okay.
My question is that I actually already have him in ABA. I actually
Okay.
found one that's covered through my insurance because I know a lot of people don't have that ability. He goes from 9 to 3, Monday through Friday at an
Okay.
ABA clinic.
Okay.
The issue that I'm having is that I'm going to find out, but with the program, they still told me to go through the public school system and have him see the child study team and everything.
Right.
They said they were only going to, I emailed them about setting up the meeting because at first I was kind of leery when they told me how many kids are in the room and how many staff members are in the room, because he would be child number 13, I was told, and there's only
Okay.
2 staff members in the room. So that kind of was a big concern to my husband and I.
Are they giving him a half day or a full day?
It would be a full day.
It's a full day. Okay.
Yeah. When I called back, because I wasn't able to attend the meeting because I work outpatient in the hospital, but a lot of people were sick with Omicron and everything going on.
Yeah.
So I wasn't able to attend the meeting, and it was virtual. So my husband did it by himself, but I ended up talking myself. But the thing I wanted to ask you is that right now when he does it, he says that they're only going to evaluate him for not occupational and physical therapy, just like cognitive skills and developmental. That's all. Should I be asking them to also do the occupational evaluation too, or they'll decide that themselves?
Does he have a lot of sensory issues?
Oh, big time.
Yeah, then he needs occupational therapy. Even if he doesn't get OT, he needs OT breaks. And he needs OT techniques, like a weighted vest or a weighted lap animal.
I do the weighted vest. We have a weighted vest at home. He does sleep with a weighted blanket at night. We started introducing that. But the weighted vest, it's a big help to him. Like sometimes if I pull it out,
He's not getting speech.
They're doing some of it at ABA, but he does have developmental.
No, but I mean when he goes to school.
Oh, he's still with early intervention in the ABA clinic. That's all that he's doing.
No, but when he transitions into school, you said they're not going to do PT and OT. Are
And
they
they
going to
didn't
do speech?
I didn't think they were mentioning speech, even though he doesn't really say anything. He doesn't.
I'd
The only
keep him
thing
in ABA and go for a half day preschool. Because if he's not speaking and he's going to be going to pre-K, he has to have speech. At the very minimum, he should have speech and OT. Are they only going to do ABA? Is that what you're saying? They're only going to do ABA at school?
Well, the ABA is private through me, that he's going to 5 days a week. I already
But I
started
don't
throwing him.
understand this preschool and a nonverbal kid.
I don't know if
who
they're
has
just
sensory
overwhelmed
issues.
or
No, but 13 kids and he's nonverbal and he has sensory issues. I don't know that that's the best.
that's
I
what I
don't know
mean.
him, so I don't know his developmental functional level. But if he's nonverbal and he has sensory issues,
He has
speech
big time
and OT
sensory
should be
issues
part
that
of the curriculum.
yeah, that's what I mean. Like that's what my husband and I said. We were like, the ABA he definitely needs to stick to because the sensory is still so large for him.
Right.
You
But
know
he
that
can get that through your insurance. He can get the OT through your insurance.
I was
in
going to ask you
school, we
that
should
question.
at
Do you
least
think I
have
could
OT.
try through my insurance for the occupational therapy?
Yeah, you could get it through your insurance. You could even
Because
get
they
PT
definitely
through
said
your
he has to continue with occupational with early intervention ending. They said he has to continue occupational. It's a big deal for him, they said.
Yeah. So then the school should be offering OT, even if it's not, pulling him out of the class for the OT, they should be at least using OT techniques, because otherwise he's going to have meltdowns in the class, especially if there's too many kids. He's going to be, in the corner doing his own thing and not interacting with kids. To me,
Right.
what you're explaining, and we can't talk about everything online, but what you're presenting says to me he needs speech and OT and ABA.
Right.
And that sounds like a large class for ABA speech and OT.
So Michelle, I will reach out to you offline. I have some thoughts about what you're presenting, and I think Dr. Merola is being very, we're all on the same page. I think there's a number of things you need, your son is going to need, and advocacy is important. So if you don't know the right questions to ask, oftentimes they're not going to offer the additional So we can talk offline about that too, strategies for you. So I think the key take home is that there's an opportunity to leverage both the medical insurance and school district at the same time. So we don't have to do one or the other. You can do both because those are tools that you have in your toolbox on that end. Thank you for that. Any other questions for Dr. Merola? I mean, we've caught a bit of her time on there. And I know you all agree with me that this was a well done presentation. Really, really insightful. I sat here and I learned a lot just listening in again to her. And I've heard her talk many times. And every time she presents it, this just speaks to the volume and the impact of the work. So on that note, if there are no additional questions, this video will be made available for you to share with friends. There was a whole segment on, the presentation of delays and things like that. And we know there's a whole host of people who don't want a diagnosis. And Dr. Merola, within the African-American community and also in African communities, people don't want diagnosis because they think that you're labeling your child. What we try to engage and get across to them is the value of having supports. And support only comes from having the diagnosis. And so diagnosis is not supposed to be a way of preventing the child from growing. It is really an opportunity. And as Pat asked that question, IEP versus 504, it makes a difference what you have, because by law, you can get supports for that child with the diagnosis. Without it, they oftentimes, even ABA companies, oftentimes, unless you have a full diagnosis, insurance will not cover the ABA.
Yeah, and sometimes too, the schools don't understand, like the argument I have with some of the schools is they'll declassify the high functioning child because they can memorize facts. And they'll declassify them in 4th and 5th grade, when now they're moving from I'm learning to read to I'm reading to learn. And that is a different, that's going from that literal learning to the more abstract figurative learning. And that's kind of where they need their support. So to take away the IEP at that point is not going to be helpful to the child. So the argument is to leave the IEP. If the child doesn't need the pull-out services and is understanding and progressing through 4th, 5th, and 6th grade, then okay. Then, you've proven that the child doesn't need the services, but to close them off and then have to reopen a case later on just when you get to the point where they're going to need those services is not a good thing. So that's usually the argument I have at that point in time.
Yeah. No, that's for sure. And as we round up, my last question is that you talked about during the 5 to 21 assessment. How often, because I know legally you're allowed to do assessments every 3 years. Can you comment on the importance of maintaining that assessment opportunities when the school district offers it?
Oh, well, I definitely, okay. Now, sometimes the school won't offer that triennial reassessment. By law, they should. And I'll usually tell the parents that if the school doesn't feel the child needs the eval, but the parent feels the child is not doing well or regressing, then I suggest they go in and they ask for an independent evaluation and a waiver for the school to pay for it. Frequently, that'll trigger an evaluation within the school to assess. I'll do my screening, and if I don't think my screening jives with what they're finding, that may sometimes add to the need to get the reassessment done. But every parent of a child who has an IEP is entitled to an independent evaluation if they want one. And that usually triggers the evaluation within the school system. Now, let's look at it a different way. If the child's doing well and they're progressing and they're improving and they're honor students within their special education class, then they're making progress. Sometimes the school doesn't do that triennial. But when I do like the triennials to be done is when the child's making that shift. The child's going from elementary school to middle school, where supports might be changed. The child's going from middle school to high school, where supports might change. I think it's good to get a good standardized testing to know where the child is beginning, so that if what they're offering them, the child's not making progress, you could go back to it and say, well, this is why, because of A, B, and C. Now we need to add pull-out services, or more individualized, or tutorial services, or in-class supports, or whatever, at that next level. You know, so when they're making those changes, I like the testing to be redone, just to make sure we're all on the same page and everybody knows what the services that are needed for the next advancement that the child has. You know, because the schools, yeah, they'll say that he's doing well. So I don't think we, you know, the curriculum's fine for him. He's doing well. He's making progress. We're mainstreaming him a little bit more. That's fine. And the child continues to do okay. But when they're making those transitions, I like something more standardized to be done, even if it's just an academic assessment and educational assessment, to make sure that the supports are going to be there if they need them.
Wow, that's amazing. Thank you so much for sharing that, because I've had many parents thinking that everything is fine, and you're right, the pressures of life hits, the stresses hit, and all of a sudden they lose the opportunity to have the support the child needs. So the value there is not lost. So once again, I want to say thank you so much for
You're
this
welcome.
amazing presentation. Many of you know that, you know, we try at my goal, our vision is to support families facing autism, our mission. And we do that by providing education and supports. And this is part of what we talk about. And the knowledge is power. Knowledge means that your child can do better because you will know the right questions to ask, the right resources to get for them, and then you can see them grow. And, you know, she used a powerful illustration earlier about the percentage of children that, you know, become declassified who do well. So it's not lost just because your child needs support. Know that they can progress no matter what it is that they will have to do in the future. So on that note, I want to say thank you everyone for joining in to this very important conversation that we've had and presentation we've had today. Dr. Merola's schedule is tight. And I know she has a long waiting list, but certainly, you know, she's one of the many neurodevelopmental pediatricians out there who do this work, and they do it because they care. I've yet to meet a neurodevelopmental pediatrician who is not passionate about their work, because it takes a certain skill set to want to do this. So if you can't get one, you can always see a neurologist, a pediatric neurologist as well too. But it's important that you get the professional supports along with you, because you're going to need it when you go through this journey. So on that note, thank you again, everyone, for joining this afternoon. Have a fantastic evening, everyone. Thank you.
Take care. Bye.
Bye-bye.
Share.